Hey, Section 7, congratulations. You've made it through. I know some of you may not take the time to even watch this video, which is totally fine, I guess. This is just my way of kind of putting a bow on this and kind of giving you all my 2 cents on these readings and what this all kind of really means from my perspective. I'll try to make it as brief as I can, but you've made it. You've gotten through the full course. I just got done checking. Everybody's good, and we're done. So this is just kind of icing on the cake. So we're going to start with the Dr. Unversgat, the upper quarter foundational exercises. As he said, one size does not fit all, right? Understanding our own personal biases. With respect to exercise prescription, I think sometimes physical therapists, if they don't lift weights, if you will, then they're not going to have their patients lift weights. And if the exercise is too hard for them, then they don't make their patient do it. And in reverse, sometimes patients who are being challenged beyond their capacity and then think, why am I doing this? So understand your own personal biases and also your belief system about damage, causing damage, right? As opposed to thinking about things in terms of irritability, specificity, creativity, individuality. What is the person needing in front of you? How can you best serve them? I've shared with some people the Chris Littlewood article where they had the 6 visits of physical therapy and therapeutic exercise and manual physical therapy compared to. So there was that group, and then there was another group that just got one exercise to do 15 reps in the functional position that was most painful. They were loaded basically with TheraBand. They asked shoulder flexion, go up as high as you can go. When it hurts, stop. And as you can go, as the pain lessons continue to go up, do 15 reps, 2 sets twice a day. That group did just as well as the group with the fancy physical therapist. So understanding that our own biases play into this, understanding that specificity can be important from a functional standpoint, individuality, what do they need from a functional standpoint, creativity based on, how difficult we need to make the person work. These are all really important, and these kinds of exercises were very well explained. Be attentive, be present, know foundational concepts, right? Foundational concepts. What's a foundational concept? Tendons need to be loaded. Rest doesn't make you better. That load heals. That stretching has minimal utility and lacking significant amount of evidence in most cases. As we state here, lecture handout is a great clinical resource. The Kahn and Scott article, I think that's a seminal article. It's written in 2009. I think it has a lot of value today. Understanding how exercise is medicine. Mechanotherapy is about what we do. It's about getting the cells to respond to load. And to be quite honest, if you take those same philosophical concepts, those foundational ideas, and we apply them in a lot of different ways. It could be applied in terms of concussions, in my opinion. So I just not in the sense that we're changing connective tissue, but load tolerance. The nervous system responds to a certain amount of stress. And depending on the health of the organism, depending on how robust that organism is, depends on how much stress you can put into that system. A very robust organism can handle more stress than an organism that's not so robust. So what does that look like? Somebody who has yellow flags, they're not that robust organism. They can't handle as much stress, but they can handle some, just not as much. That person who just sprained their ankle but otherwise is totally fine, has a supportive family, doesn't have external stresses, just wants to go back and play, they're a more robust individual. They can handle more stress. They will be able to progress quicker. Both people are going to get better. We treat both people with compassion and understanding, but understanding that one system can tolerate a little bit more than the other. It doesn't make one better than the other. It just is what it is. But that Kahn-Scott article, I love that one. The Reinhold article is very good about, gives you some really good understanding biomechanically, gives you some really good understanding, even from an exercise standpoint. But one thing I'd like to share with everyone is this comment that was under the recommendations. It says, a common recommendation in rehabilitation is to limit the amount of weight used during glenohumeral and scapulothoracic exercises to assure that appropriate muscles are being utilized, not larger compensatory muscles. I cannot tell you how many times I've seen this being discussed about, we need to not do this, or we need to be very attentive to this. Shoot, it could be applied to transverse abdominis, for crying out loud. and low back pain. 2 recent studies have analyzed this theory and appear to have proved this recommendation inaccurate and not necessary. Nothing happens in a vacuum. When you load a system, you get a cumulative effect of firing. Now, could you isolate at times? Maybe a little bit, without a doubt. But when I give somebody a 10-pound dumbbell and I say, I want you to do a lateral raise, that is loading the rotator cuff. That is loading the glenohumeral joint. That is loading the upper trap. It's loading the lower trap. When I put a person in side plank and I force them to hold that position, again, it is loading the glenohumeral joint. It is loading the side. It is loading the trunk. Put stress on the system and then make it work harder. One of the things that frustrates me the most is people doing some simple exercises that they may have started off with as appropriate because of a poor tolerance, but then they continue to do that with a orange TheraBand, or maybe they'll go up, God forbid, to a green TheraBand, as opposed to putting a 10-pound, 15-pound dumbbell, 20-pound, 25, dare I say 40-pound dumbbell in their hand, and making them load their system progressively. So that was I love that statement in the Reinhold article. The McQuaid article basically just talks about what a bag of hurt the scapulothoracic joint is, and how we really don't know what's really happening there, and whether dyskinesia is really important or not, or really is it an offshoot of something. And everybody was pretty much on par with this, and everybody really understood the dynamic system theory, that we are, again, a robust organism that handles things in a multiplanar, has to be able to handle things in multiplanar directions with various levels of load, is kind of who we are. And we don't really know outside of that what more we can say about this area. So scapular mechanics do not tell the whole story. As a matter of fact, speaking of which, I was just at the University of Minnesota. I had 3 lectures this week. It's kind of how I finish. So I have these 3 lectures. That rarely happens, but I had these 3 lectures. And one of the grad students working with Paula Ludwig was down talking to me. And I was asking her about what she's planning on doing. And I started to say to her, we need a better path forward. And obviously she totally agreed. We talked about how the scapular mechanics are really not a telltale sign of anything, and how we need better research. And of course, she's talking about how she wants to better understand scapular mechanics, and Dr. Ludwig is going to help her with this. And I said, well, so how do you feel like you're going to gauge your study? And I guess my point here is that even she, as a PhD doctoral student, is very limited in what she can do. And she's like, well, to be honest, to get the number needed with symptomatic patients, and to be able to categorize them and to appropriately assess them with, I can't remember what she was going to use, some kind of fluoroscopy. I probably won't be able to do it. So I'm going to have to use asymptomatic patients. And then maybe someday, if I were to get tenured, or if I were to be at a research position at a university, I could build on that. So here I have a PhD candidate even describing to me how it's not so simple as just being able to go grab some people with achy shoulders, right, and just figure this out. That it's obviously much more complicated. And obviously that's without saying, because if they could do that, they would have already done it, right? So it goes without saying. Okay, so we talked about that. So finally, I just want to make a couple comments on the case study. So, all in all, I think the guy did a great job with the case, right? He was extremely thorough, almost to the point ad nauseum, right? Even the patient was kind of like, geez Louise, buddy, that's just my elbow. That's all that's bothering me. What's with the extensive evaluation? And, I think for people who are in the fellowship, the key here is that fellows should be able to adapt their evaluation quickly and on the fly, knowing that if things aren't going the way, if they aren't as clear-cut and dry as this particular patient was, which was pretty clear-cut and dry, that you can expand your evaluation or contract it based on the person sitting in front of you. And you can do it really quickly because you know going in how to make those changes. You know what a full one looks like, and you know what a modified one looks like. One of the things that I thought he could have done a better job was explaining the effects of loading. I guess I didn't really, from him, I didn't really get the sense that he had read the Scott and Kahn article, and that he was explaining how mechanotherapy alters that loaded system. I think this person, you want to talk about a robust organism? This person was a robust organism, right? He didn't have a lot of other things going on. It was very isolated. It had low irritability, like that thing you want to load. And I would argue that he could have probably loaded it even more, like 4 or 5 pounds. Yeah, I'm willing to bet you could go easily 10 pounds to get a similar effect, because you're not going to get that connective tissue change unless you load that system. And I don't know, it didn't seem to me, and I could be wrong, it didn't seem to me like that was enough. And then explaining the benefits of manual therapy. So I posed this question to one person, I think, but it did set me off a little bit because he talked about he was increasing blood flow to an area. And I would be like, well, no, that's not really why we do manual therapy, right? We do manual therapy to reduce pain. And how do we reduce that pain? Well, we know that quick stretches, and we know that taking that joint and stretching it back and forth, sometimes with greater vigor than others, and sometimes with just a little bit of vigor, seems to have an analgesic effect at reducing pain. So that then we can go load it more aggressively because it decreases irritability. And I wish he would have used those words to help him better understand why it was important that he was going to do this self-mobilization. And again, I would even argue, was that really necessary for somebody who wasn't that acute? In my mind, he wasn't that acute. I would have done that with somebody who was having a hard time just with gripping, with a pain that was like 6 or 7, right? Not a 2, 3, or 2 or 3. It just didn't seem like it was necessary. But again, this is my opinion, right? And I think I could have been totally wrong. I pushed him too hard, and who knows? He would have come back and said, "You made me worse, man." You never know, but that was my sense. Lastly, we've crossed the finish line. Congratulations. You're done. You've completed your 8-week course of upper extremity, and I appreciate everyone's hard work. I appreciate being able to listen to everyone explain their rationale. I appreciate the dialogue and exchange that took place. I appreciate the courtesy that was extended to everyone and the willingness to engage on a level of professionalism. So thank you. Pause and reflect on what you've learned, right? Keep these tight, but understanding that don't keep them too tight because evidence-based medicine is constantly moving forward. And I think it was Jose. I can't remember. Somebody posted the simple shoulder evaluation paper from 2015. And then I reposted the Meekins article for 2019 that said that was not reliable or valid. Like, that's a classic example of how evidence is moving forward, and we too need to be kept up on what's happening. Do not stop expanding your horizons. Let your learning and your journey continue for a lifetime, right? We are growth mindset, evidence-based. We do not stop. What we know today may not be true tomorrow or the next day or the time after that. So it's great that you have this base, but understand that you need to continue reading and educating yourself. Best way to do that, if you don't like to read at journals, is go to conferences, right? Go to CSM, even though that's a big one. Go to AOMPT. I love AOMPT. This one is in Orlando this year. It's just got such good stuff, and it really parses the literature and science for you. Excellence is the best defined as the purpose of ongoing improvement. Never stop learning. So it's been a treat working with all of you. I wish you all the best and luck in your future endeavors. And if ever there's anything I can do, don't hesitate to reach out because all my students, I'm always willing to go an extra mile for. Take good care and enjoy your summer.